Hello, everyone. It's a great pleasure to welcome you again for the first webinar of the new year. I think it's a very fascinating topic. We are all dealing with a rare disease, sarcoma, and to move forward, it is very critical that we share data, that we interact with each other, and for that, we need to build networks, we need to communicate with each other, and that's why we want to learn from those who have the most experience. I point here to France, Spain, and the CellNet. And I think it's really challenging on the one hand. On the other hand, I think we only can learn from the experience you will share with us. And I'm really very honored that Jean-Yves took on this challenge, and he will lead us through this topic. Please, Jean-Yves.
Thank you very much, Bruno. Happy New Year 2022 for everyone. I'm very happy to be with you today, and happy to share with Javier and Axel a discussion which is really meant to be an informal discussion on this question of the challenges in creating a group. And when preparing this this presentation and this setting, sorry, I'm sharing my screen. Actually, when we were preparing this presentation, I think it was interesting to have a historical perspective. So you will be probably surprised to see progressively slides which have been taken from presentation which sometimes date some 20 years ago, just to show actually what was our track, what were the many challenges that we had during this travel, the things which could be done and the many things which could not be done, as we are going to see, and probably what would be more interesting is the discussion and the shared experience, because the history of this French sarcoma group is very specific to the national healthcare system, I think, we have in our country, and probably each country will have a different type of oh, sorry, I make sure that okay, excellent. So you will have the pleasure to have both English and French slides. Some slides were not translated. These are the conflicts of interest as a researcher and as director of my center. Okay, so for some reason, okay. So we started quite a long time ago, actually. It started with pathologists. And I think that's very important to have this history in mind, because pathology in 2022, more than 40 years after the creation of what was not called at this time the French Sarcoma Group, it started because pathologists were gathering under the supervision of Jean-Michel Coindre, creating the French FNC-LCC grading, which later became, with some adaptation in a different version, the WHO grading. And it was actually organized, FNC-LCC means the French Federation of Cancer Centers, in the 20 cancer centers which were existing at that date. That was the history of this group for actually many years. And around pathologists were gathering physicians and medical oncologists to build on what they were describing, the history, the classification, the histological classification of the tumors, and this was the first step by which we actually initiated the first clinical studies. But the first clinical studies really took long to be created. And it's probably not before the beginning of the 90s, I will not get too much into the detail, that formal French sarcoma group, as we call it here, was created around this 20 French center, which was later open to other public hospitals and private structures treating cancer patients and sarcoma patients. In 2010, at the time when we merged the French sarcoma group with the GETO, which was a group of physicians working on bone tumors, there were 54 institutions, which is basically close to what we have right now. Note that there were some institutions which joined at that time as partners of the not only French sarcoma group, and this was basically the distribution in the country of the center at that time. So when the group was created, it has several objectives. Remember that we had basically no budget. It was a group of investigators in comprehensive cancer centers which had an interest to work on sarcoma, building on the activities of our French pathologists who were very much refining the classification. And while they were doing that, we understood that there was very much a strong correlation between the interest in working on this tumor and the quality of patient care, and that obviously the lessons which we obtained from our friends from the Nordic countries in particular told us that we definitely needed to be concentrating the treatment in a limited number of centers, and if not able to do that, educating as much as possible the general physician and the oncologists and the surgeon taking the challenge of treating those patients to the rules of the treatment. And this took us, I would say, several years. Probably was the work which was done between 85 and the end of the 90s. And this challenge actually led us to the subsequent tasks that we are going to discuss at the end of this presentation, which was NetSarc. Pathologists were at the beginning, and pathologists brought us to translational and clinical research. Also linked with that, and with the support of an international group, which is a key group I think, for the creation of the of all national groups, was the ERTC and the ERTC soft tissue and bone sarcoma group, which used to be the place where we were doing clinical research in sarcoma for many decades, and from which we emerged as national groups for various reasons. In particular, the reason that we had so many questions to address. Many questions on pathology, many questions on clinical research, as we are going to see. This evolution of a small group of comprehensive cancer center to a larger group of reference centers in country allowed us to generate progressively databases and tumor banks. It started with the FNCLCC soft tissue sarcoma database and tumor bank, frozen tissue bank, which were always virtual and are always virtual as we speak. They are not centralized. They are all in a single, each individual center, but we can identify them in a single database where we can get the information. And this was helped with something which was critical, again, for the building of the project I'm going to show you, which was a grant obtained in the early 2000s called Conticanet, which was a network of excellence in the 6 framework program, which helped us to generate the first database at the structure that we have right now, and to maintain that after the end of the project. I was mentioning that the connection or the starting point with pathologists led us to connection with molecular biology, and that was a key asset of the group, I think, to have this connection. And basic researchers, really basic researchers, were very instrumental in helping us to define new entities, molecular pathways, identifying molecular subtypes, and the molecular grading, which was published some 10 years ago by Chibon and collaborators in Nature Medicine. This molecular grading was actually the end of a long travel where several entities were identified within this group. And as I mentioned, in this first period, the education and improvement of primary care was the main objective of the centers which were involved in the French sarcoma group, with the main activity which was creating national clinical practice guidelines at that time, and continuous medical education for all the regions, all the centers in the different regions, an activity of training which was oriented outside the reference centers. We were doing clinical trials at the time, but there were very few clinical trials which were truly activated. When we started at the beginning of the 90s, there were probably less than 10 clinical trials in total being conducted, all academic clinical trials. Again, the connection of the group and some of the centers of the group was a connection with the EORTC. I was mentioning that we were helped by a 6th framework program grant called ContiConnect, which had the aim of improving the quality of care of in sarcoma and improving the knowledge and clinical as well as translational research in sarcoma. The broad type of indications and aims, which was typical of the network of excellence. In this program, we within the region where I work, initiated one study which proved to be quite important for the rest of the story, which was actually very much connected with a copy-paste of this study conducted in Italy on one side and on the Aquitaine region of the other side. The story is a story was done in this region where we, Rhône-Alpes region, where I work, Lyon is here. We contacted all pathology labs, 100%, and all pathologists in the region, asking them, okay, guys, would you agree to send us all your sarcoma or suspected sarcoma during 2 years for them to have them reviewed? We expected something like 150 sarcoma at the time, and actually per year, I mean, and actually we received very much more. Actually, the inclusion, which were really confirmed, were 2.5-fold higher, and there was actually even a larger declaration. I will not come back to that. The point is that we observed that we have more sarcoma than we initially anticipated. And because we were granted initially by a small grant regionally, we could expand this study in the Aquitaine region and the Veneto region with a population which are also quite large. And this enabled us to do something which was quite important, to look at the histological discordance between the primary and the secondary diagnosis. And the bottom line is this one. When central pathology review is not conducted in all studies that we did consecutively, when it is not done, a significant proportion of patients is misdiagnosed and therefore mistreated, and this is costly for the social security system, and there was something to change in the healthcare system. This was also correlated to outcome, and when you look at the survival, that's a +1. It's going to be better viewed here with magnification. When we were looking at the outcome of patients treated according to guidelines or not according to guidelines, there was a significant difference, and importantly, the center where they were treated was also critical. That's overall survival. That's in red, centers treating patients treated in reference centers in the region of the test, which were treated according to the clinical practice guidelines. This was cost effective, and this led the French National Cancer Institute to generate a program which proved to be very important for us, which is NETSARC, but which was not only for sarcoma, it was for all adult rare cancers. So there were at that time 20 subtypes of rare cancers which were identified. NETSARC was one of the program. Actually, there were 2 programs which were granted, one for pathologists called REPS, and the other one for clinicians called NETSARC, which were later merged, but which were basically the same centers. So NETSARC, now called NETSARC Plus because it's a merger, started with 26 reference centers, 3 coordinating centers, as we call them. Why coordinating? Because this is a place where pathology is being reviewed most of the time, and all the reference centers, beside have this activity of pathology review for their own region, and their activity of being the place where multidisciplinary tumor board were conducted. So one thing here which is very important that I want to stress, this is a French sarcoma group, and NETSARC is a grant. It's only a grant, but we were lucky enough to have this grant since 2010. And I did not put number here because they are, but they are important to hear. The amount of money that we get from the nation to organize that is not that much. It's about 400,000 euro per year for all the centers, but it was proved to be critical to generate this. This is a database of NetSarc, which is online. If you look at NetSarc Plus or BCB sarcoma, as you can see here, you can see up to date. That was the last time I did a screen. This is in French, sorry, but you see primary tumors, sarcoma for the majority of them, more than 100,000 patients since 2010. Included into clinical trial, you see about 5% of them. Seen in a multidisciplinary tumor board, close to 200,000 patients presented, molecular biology available in 10,000. We would not have done that without the support of this grant. And of course, that helped us to do many things which we published and that you probably know, including this nationwide incidence of sarcoma, which actually proved something which was a bit of surprise, I think, even for us, which was that the incidence of sarcoma is closer to 10 per 100,000 per year than 2 that was reported in major papers some 15 years ago. Simply measuring that enabled us to do that. And one thing which is critical also here is a decision which was taken in early 2010 on the basis of the previous experience I was mentioning with Conti-Canet, which is that the French Ministry of Health made it mandatory for sarcoma to be reviewed by reference centers. So we know that we have all patients, because if a diagnosis of sarcoma is suspected or done by a primary pathologist, she must send it to one of the reference centers for confirmation. And with that, by the way, we reduce the number of patients with misdiagnosis. Actually, everyone improved altogether, but more importantly, we could get everyone in the database, which is exhaustive. So the exhaustivity is interesting because here you see super rare tumors, less than 1 per 10 million per year, less than 1 per million per year, and 1 per 100,000, and between 1 per 100,000 and 1 per million. And you can see with these blue and green boxes that actually, which correspond to the phase 2, randomized phase 2 and phase 3 trials, that the majority of tumors do not have clinical research to guide their treatment, do not have at all clinical research, which is of course an information that we know, but which is interesting graphically to see. So database, funding, mandatory review, and database which include a very narrow set of data. I'm speaking a lot about this database because, as you understood, NetSarc is a project, and the French Sarcoma Group is a group. But this database is very much what we are around. This is very much the cement between the centers of the French Sarcoma Group, and it helps us to do some studies which you may have seen, but which prove to be very important by many aspects. The first aspect being that we convince the health authorities that this was a useful exercise and not something which was a misuse of public money. So in this database, we decided to put some clinical items, but a very limited set of clinical items. Basically, I don't remember the exact number, but we are close to 25, including, of course, follow-up. And follow-up enabled us to do some important reports, which were actually destined to the health authorities so that they can see what was going on in the country. In this case, what is the proportion of patients which were referred to a multidisciplinary tumor board before treatment? And we observed that patients who were referred were to the reference centers were patients with a worse prognostic factors, larger tumors, older, metastasis, etc. That the treatment was conducted better in reference centers. No surprise, but we needed to measure that because it was, I think everyone was quite surprised for these numbers, but this was very important, of course. And initially, in the first report in 2016, an improved local relapse-free survival, no impact initially on metastasis-free survival, followed later on by a study of how important it was to not only see the patient before in the MDTB, but to treat the patient surgically in the reference center. So that was a series, an updated series with close to 30,000 patients, a bit more, which was also quite interesting in describing the natural history of the tumor, and which was proving something very important, which I show here, which is that the quality of surgery conducted within NETSARC in terms of R0 resection, 53% as compared to 15%, is very significantly superior. So better surgery in NETSARC center, less reoperation, and final result, which is anyway, even after reoperation in a NETSARC center, worse when the patient is operated outside. I mentioned that it was cheaper in the initial region. We are trying to convince the health authorities that they should grant treatment of all patients in reference centers, but contrary to our friends in the UK and in Nordic countries where we have not managed to do that. Despite this showing with a larger update that the survival of patients treated in reference centers here in green, overall survival, is superior to that of patients treated outside. The hazard ratio is close to 0.6, which means that a 40% death reduction as quickly as 40 months. This is a map showing how we organize ourselves around this network and how far the region are for the closest reference center. The good news, and I will not show the data, but that was one of the questions which was raised, is that the color and the distance to the closest reference center is not a prognosis factor. So this is massively a collective work. And these are all the contributors, whom I cannot quote, but you see the large, very, very large number of members of the French Sarcoma group, close to 300, a bit more actually, who were pathologists, clinical oncologists, surgeons, radiotherapists, radiologists, and pediatricians all together in that. And this actually also helped us a lot for the building of here in Huracan. So every year we have our meeting of the French Sarcoma group, where we present the results of NETSARC, and we see that now with a mandatory pathology review that we are plateauing in terms of new cases being seen, that we are improving progressively the number of patients which are referred to the centers in the first place. Initially, in light blue here, you see the majority of patients were referred second hand. Now we see that the patients are sent to us first hand, and that's of course the best scenario for pathology review. Also to observe the exact numbers of the different sarcoma subgroups and tumors of intermediate malignancy and GIST, which basically since 2015, actually 2013, has been plateauing, possibly with a slight exception of 2020, where there was possibly a slight decrease related to COVID, as it seems. And this is true for all subtypes of sarcoma, bone, visceral, and soft tissue. So with this database, we are able to measure what we have nationwide. When is a patient presented to the MDTB? Is it before the treatment? Is it at the time of diagnosis? What is the quality of, what is the type of diagnosis tool that we use, as shown in this slide? Do we do better over time since 2015, but also 2010, which is not here? We see that the majority of patients are actually seen in this group. Majority of patients are presented to the MDT before the first surgery, before the first treatment, sorry, including before sometimes the first biopsy, which is of course what we aim for. One interesting point on this question is that we have a limited number of centers. I mentioned that we were 26. Some have been merging. I do not show who is who, but you see that there is a huge difference in the different centers in terms of numbers. And one may think that this could have an impact, because for many networks, the number of patients seen per year, it's a number of patients seen over many years. The number of patients seen per year may be a prognostic factor for patient outcome. Actually, this proved not to be the case. And this was particularly spectacular in a study which was reported by Sylvie Bonvalot on retroperitoneal sarcoma, where again, the outcome was superior in patients treated in a reference center, massively superior, by the way. That's overall survival. It's hugely superior, but there is no difference with a number of patients, which means, and for me, that's very surprising, but also very interesting to see that actually it's less the number of patients that you treat, which is important, than the engagement of a multidisciplinary group of investigators working together on a weekly basis, interacting with other centers, working to do the best practices. And with that, actually, the outcome of patients in this complex surgery, which are retroperitoneal sarcoma, are actually not significantly different in those centers treating more patients than in centers treating less patients. So we decreased a bit the number of centers. We merged some of them for practical reason. You see here some of the merger here and here as well. This is the structure of the French sarcoma group board, actually. And that's probably one of the lessons that we also took over the years, that it was very important to be extremely inclusive in this board. Although people basically raise their hand and want to commit themselves to work within the group to generate actions, whichever they are, education, training, research, etc., are welcome. And that's probably an important number, because you notice that I've not spoken that much of clinical research. I would say only a few words on clinical research, but this is the evolution of the management of sarcoma nationwide since 2010. In blue and light blue and dark blue, you have the patient age under 80 or above 80, presented before treatment to the multidisciplinary board. In yellow, light yellow and dark yellow, same for the age, and biopsied before, so we improved. With adequate imaging before, we improved, but we were slightly better at the beginning, so it improved overall. What did not really improve, actually, is the participation to clinical trial, which is overall in the range of 6 to 10%, depending over the years, with the exception of the dreadful COVID-19 2020 year. We can do better. It's close to 10% overall. We don't take into account in these numbers that of real life studies, which add up a little to these numbers, but for prospective clinical trials, that's about it. The majority are academic clinical trials. Some are pharma-driven clinical trials, and this is something which is quite open. The point is that that's a place where we have not very much been increasing over the years. So that will be my conclusion. That's a long story. That's close to a 40-year story that I've been trying to summarize, which started with pathology and molecular biology, which introduced clinical research later on, which was mainly academic research, which was later on joined by pharma trials, where again the networking activity is very fruitful, because even though, as we all know, pharma opened trials in only a limited number of centers, the referral process within the group enables some patients in any site of the country to be addressed to the closest center, which is open quite easily, with the support of with budget support and everything. So that's very useful. The concept of reference center, which was actually created by our friends from the Nordic country, proved to be very successful in this country. But for that, it needed to have this mandatory pathology review, and we still expect a mandatory referral, which would be critical. What is a cement now of this group, I guess, is less clinical research, even though we are all by training and by aim clinical researchers, I guess, but the database that we are constructing, which is so important to link people together and also to measure what we are doing and what we are not doing properly. So that's very important. This database is a treasure, but it's a very expensive treasure to maintain. And the funding that we are receiving is now not sufficient to update. And here we are going to have a problem. I don't know how we are going to solve it, and together we try to think how to solve it to do better.
Okay. I think having Javier among us as well, maybe you want to take up this point and extrapolate on what we heard to what is different in the Chais and also in the CellNet, and how you, let's say, how you face the challenges from your side. I'm just at the top of your head. And then we start the interaction.
Okay, thank you. This is Javier Martin. Terrific history of French Sarcoma Group. And I remember that in the 90s or maybe in the early 2000, our mirror in terms of registry was the Memorial Sloan Kettering Cancer Center, but now is for sure the French Sarcoma Group. It's incredible the effort in this sense, and the registry in rare disease as sarcoma is, as Jean-Yves mentioned, is very, very relevant. So our history was a little bit different because in the French history, pathologists were the pioneers that succeeded a lot, because actually we are using their French grading system in our daily basis diagnosis for soft tissue sarcoma. So it was very, very important, the basement of the French Sarcoma Group. Our history started in 1994 with the join of several medical oncologists. So our core as a Hayes group was initially medical oncologist. And we have an expansion phase up to 2000, and were new multidisciplinary members added to the group. And I think our critical history was very important in the 2011, where we have a strategic plan with the help of PwC, and we focused on four different objectives: the research block, educational block, and clinical care block, but also the financial block. And one of the first thing we did in that time was to know what are doing other cooperative sarcoma groups, French Sarcoma Group, Scandinavian Sarcoma Group, SARC, the American Sarcoma Group, Australian, Italian Sarcoma Group, etc. And one common denominator was that every sarcoma cooperative group had some infrastructure. So this was important in order to make their own studies, because you can have a very good idea, you can be very persuading, very convincing to the committee executive board of your group, and maybe you are very persuasive also with pharma. You are able to prepare a protocol, but then you have to face with the CRO. The CRO price is extremely high to put in action any clinical research, any phase 2 trial, for instance. And this is why we consider very seriously to have our own structure, our own database, and this allowed us to grow in, I think, in a very good fashion in the design of several clinical trials. And also the distribution by working areas was important in our group. This was a try to make wider the base of involvement of several multidisciplinary participants. And this was, I think, stimulating, because with these areas there were more responsible people within the group. Now we have more than 500 members. Medical oncologist is not the most common. I mean, there are more no medical oncologists than medical oncologists. And we are very concerned as well to potentiate research grants, and we are launching several programs across the during the year. And of course, the educational block, it was important as well, and not only to update national clinical practice guidelines in sarcoma, but also organizing the annual international HAZE symposium, or advanced course for senior residents, or to offer a university master degree on sarcomas, or maybe editing books on sarcoma. We have a website as well that could be a tool for educating purpose. And clinical care block was very important for us, because on the contrary to France, Spain is a decentralizing country. I mean, there are 17 different healthcare providers, and this is a very difficult question, because the HAZE group is going in the opposite sense, trying to concentrate patients in very few hospitals. And this was a very huge effort, but in the end, the health ministry of Spain, that is more or less testimonial, because as I mentioned, the health provider is referred to the region in each region, but some of the task of this health ministry was to order some equity in the health distribution, and we convinced them that the importance to have reference centers in sarcoma, and finally they were in the same line. So this was very important issue of HAZE group, and now there are 7 hospitals considered as a reference center for sarcoma care in our country. So this was important. And also the HAZE group has the activity in clinical research is important in order to design clinical trials. I am currently designing the 80, I think it's the 86 study, which is very nice number. Yeah, and as I mentioned, the financial block was important. That means to consolidate the position of some the position for that allow us to grow, and this is also important. I will be very happy to answer some questions or comments around that, but this was a summary. And just to outline the differences with French Sarcoma Group. But importantly, one of the very important thing is the international cooperation. We are performing or participating in different clinical trials or different observational studies across Europe and beyond. And this is also very stimulating and very convenient in sarcoma, because as you know, increasingly we are designing trials in a very few sarcoma subtypes, and this means we require an international cooperation, not only ERTC, but also the cooperation between national cooperative groups. So this is all. I'm very happy to answer questions or comments, and for sure the French Sarcoma Group is a very good mirror in many issues in sarcoma care.
Thank you so much, Javier. Do you want also lose some words about the CellNet, or do you think that covers for the moment?
I think CellNet is is a grant. It's true that it now is a consortium made possible because this European grant. We are more than 40 hospitals across Latin America with the support of some centers in Europe. And it's true that the willingness of the participant in several centers with the sarcoma experience in Latin America is to continue. So we are actually made some steps in order to make a legal entity for continue CellNet consortium. Hopefully there will be 2 years still under this umbrella of European Commission, but then later on this date, maybe we should decide if we continue as legal entity. And I think it's very, very important. It's another situation because the difficulties in Latin America maybe are difficult. It is not easily extrapolated to Europe, but yeah, the beginning is hard time, but is in any case is necessary. So I think there are different speeds as well in different countries in Latin America. And the important thing that is we are initiating projects in a cooperation faction, and this is a transforming force because in some countries already they have decided where are referring patients with suspicion of sarcoma, and this is important. So in the end, this means a transforming reality, and this is very, very, very important because this is the fruit of this task, this cooperative task. But I think CellNet is, yeah, we can present maybe in the future where when the CellNet had more experience, I think.
Thank you so much, Javier. Axel, obviously, together with Jean-Yves, you are the motor, or still are, and you were the motor initiator of the French Sarcoma Network. And as Jean-Yves summarized, it's a real treasure that you built up. Having now heard all this, maybe you just want to comment from your side and with your own words.
Yeah, I think I have 2 or 3 more messages regarding the creation of this kind of group. More we are well organized between at the academic level, university and whatever, and more the health authority help us. In other words, when we have proved that we make 2 million of economy when there is a systematically review of pathology slide, of course, health authority help us. So health authority help a very well organized group when we have the possibility to give an exhaustive number of sarcoma in 1 year. So more we are organized, I think more the authority help us. The second challenge, and maybe to our strengths, you have seen the number of list of member of board of there is a rotation in the board of French Sarcoma Group. I think we have to push senior and junior to have specific missions within the group. I give you an example for when we give a topic like angiosarcoma in Lille. Today, 10 years later, the different company worldwide contact directly one center to build protocol in angiosarcoma. Same thing for leiomyosarcoma in the south of France. So to give missions to each of one, to try to have to push the community to work together. So a senior and a younger. And the other important message, we have not to mix quantity and quality. And our limits, we have a large number of patients in the database, but our limits is the quality of data within the network. We need more data coordinators to check the files. Sometimes it means the grade, it means the size of the tumor. So we have a large number of patients, but we have to come back to the dossier, to the files. So it is only to share with you not only the strengths, but also the limits. And we have a lot of limits, of course, not to mix quantity and quality.
Yeah, what Axel is referring to is really our major concern. That's the update. I think the quantity of data that we have is limited in terms of 25 items per patient. But the challenge that we have is how to update with CRAs 100,000 files. There was a discussion some 2 years ago with our network coordinator, whose name is Françoise Ducimetière, and Axel remembers very well this discussion when we said, okay, we stop 1 year and we update everything, or we continue, but we do not update. And the decision was made, it was a tough decision. The decision was made not to stop, because we thought that we could find a way to update. And actually, we are trying to find a way to update, which is to link this with electronic health records of the nation, which is now open and can be accessed. So if we know that the patient is alive, that's an important information, of course, and that can be done automatically. But that's a big, big challenge. And as said, Axel, the numbers are of course very important, but the content remains limited by many aspects.
I think I see a common thread now. In the preparation of this webinar, we asked all the participants, to submit questions that they have, and of course the questions were huge. And I think there are different steps, and something which I never forget what Axel taught me in the very beginning a few years ago. Well, the most important thing is to bring together the willing. Of course, the thoughts are spreading, but and everyone has an own opinion. But I think you have to condense a nucleus where you can bring people together. I think a second point that the French sarcoma work and Javi also pointed out is, of course, the path review. I think, of course, you showed that this is absolutely critical. And the third part I think we have to discuss then too is the data management. I think you summarized that also very nicely. I think coming back to, let's say, to the first part, I think is kind of obvious, although not always least. But I think that's the key. Regarding pathology, I mean, there are many issues that I went through my mind when I was listening to your really interesting talk and your numbers. But you said reference pathologist. How is the reference pathologist then defined? How is that solved? Let's say in your networks. What defines a reference pathologist?
Yeah. That's a very interesting question, because actually it was it started with the group I was mentioning, and it expanded on this group without stringent criteria of numbers or whatever to be which were made. Actually, there is no threshold number of pathologists of slides seen per year. It's really a commitment of every day, every week to the activities of the group by the reference pathologist of the reference centers, which is a key item for that. So when to say it differently, when we had to put numbers to put the threshold numbers in Huracan, for instance, to identify reference center, we were not that comfortable because we had no numbers. We had numbers to propose, but we did not find a threshold number. So it's really the commitment, the lifelong or the long-term commitment, in the activities of the group, which is a key factor. And that's the case also for clinics, as you have seen.
Yeah, in the case, yeah, we have just a pilot experience now conducted by the pathologist within the Hayes group, and they have selected more or less 15 pathologists with experience in sarcoma, and they have proposed a peer review. It's very simple. And this is a observational study, prospective observational study, and just to check, to make double check of the diagnosis, local versus, let's say, more expert pathologist. And this will take 5 years, more or less, and we are starting now. So this is our situation. And in the meanwhile, many centers share cases to another place. Maybe molecular ancillary test has been very helpful in some cases. Maybe in others, the pathologist requires other opinion. So we are very free to share the cases. And obviously we promote that. We promote the sharing the cases if the pathology diagnosis is difficult, and we are detecting that in the weekly sarcoma committee. So this is our situation.
Great. Axel, any words, comments from your side in this respect?
No,
okay.
Pathology is a key issue in the field of sarcoma. And one sentence we have now mandatory at the end of the pathology report: these patients have to be taken charge in specific center, because it could be, or it is, or it could be a sarcoma. So we have changed the mentality. It was one of the key issues of the report of the pathology. Even for the radiology, it could be a sarcoma. So here you find the list of the specific center in France. So to help radiology and pathology to try to, for the care course of each patient, because the objective is to increase. It's impossible for some centers to take in charge all sarcoma in France. The objective is in each region, it is to offer the best quality of the care course of the patient from the beginning to the tumor board, to increase the knowledge and the taking charge of the patient, to increase survival of all patients, not only in field centers.
If I remember Jean-Yves' numbers correctly, what he said, I think you said that there is not yet a mandatory referral. Right. But if I understood you correctly, let's say you aim in that direction, and how would you define that? I mean, based on what Axel now said too.
I think the only way is to redo what our friends from Nordic country and the UK have done, which is a decision by states that only some centers can treat these patients. But this is very complicated in a country like ours. But I think that was the best decision that the Nordic countries and the UK took for that. We have been trying to convince, and we improved, but that's not enough.
I think you also pointed out really correctly that, as Axel said before too, there is help from, let's say, from the government required. Another fact that intrigued me during your talk, did I catch this correctly? You said that, let's say, from all the million sarcomas that you have in the database, there are maybe 15% presented at an MDT. I mean, if this is correct, on the other hand, you showed how important the MDT is. I think another important statement that you made is the MDT discussion for a patient is so much more important than the pure numbers. If this relation of, let's say, some 15% is correct, how can we improve this? I mean, is it then just a referral, or are there not enough MDTs? How can this be improved? Let's say that from 1 million sarcomas, 117.
100,000, not million.
Okay, but what maybe the relation between MDT and sarcoma diagnosis?
Yeah, I wasn't clear. I realize that actually it's 50% presented to the MDT before surgery, before any treatment actually. All of them are by definition presented to MDT, either after, but we have nothing to say other than you follow the patient. But they are all shown, almost all, it's not all, but 95%. I did not show these numbers. So it's a time, 50% is a time, now it's 54%, I think. It's a time, the proportion of patients who are seen before the first therapeutic event. And this improved actually. And this was the way by which we increased. At the beginning, Axel, it started with 30%, right? Something like that.
30 to 50 now, 45.
Yeah.
I think
the objective will be theoretically to see 100% of patients before any treatment, but it's impossible.
We are far.
Yes. I think that the next big challenge that we have to discuss is data interoperability. I mean, of course, this includes everything in terms of, on one hand, quality. How can we improve the quality of the data? And on the other hand, where do we want to go with the data? Let's say, in my vision, I think we need to have, let's say, the goal needs to be real-time data, which allows deep outcome prediction analytics. What are your thoughts on that? Maybe just all of you.
Javier, you want to start?
Yeah, I think, I don't know, in our experience, we have data and we have registries, but our registries have been different programs. No, unfortunately, we are not registering all the cases because we don't have any budget, a specific budget for doing that. But we have put in action some programs just to check the quality of margins in surgery or the other quality items. So yeah, maybe the most important, I think, in our country, the most important issue was to be very clear in the objectives of any registry. And depends on the objective, you will build the database essentially. But obviously, it's a very good tool to check the quality over time. This is the case for Scandinavian registry as well, where the incisional biopsy as the first diagnosis method was decreasing over time. And this is in some way a very good news because the biopsy core was increasing over time. So this is in some way is a very good tool for checking quality. I think this is one of the useful version for data, I guess. There are many of them, but this is one of more translational version of the data.
Can you allude to the focus of your? Can you please allude to the focus? Go ahead, Axel.
There are for me two moments where the quality have to be careful of the quality of data. One, it is when the patient is discussing the tumor board, and we try to have the same template when we make a report, when we take a charge of patient, because we have not to forget that there are not doctors. We implement the data. It's a data coordinator. So we have to be careful when we make a report to try to put a template where there is all the important message, size, the grade, the localization, the age, blah, blah, blah. So improve the template with all the items we need. And then the second option, when we see a patient who relapsing or patient death, we have to come back to the network to put all the information of between the diagnosis and the relapse or the death, to have maximum of information all the life of the patient.
Do your registries include a longitudinal follow-up of all the patients, or how did you solve this issue?
We try in big center, because we have a specific data manager for each coordinated centers. We pay a data manager only for the job to implement all the items in our own multidisciplinary tumor board. And then when we see the patient in consultation, or we have information of the death of the patient, or of a new surgery or relapse, we come back to the files, and I give the information to the data coordinator to put this information in the network, which is an everyday an important issue if you want to increase the quality of the data.
Javier?
Yeah, the only thing I would add would be that it's possible to extract the database for the information that we have, typically size, age, gender, grade, stage, these type of things. We can extract the date of diagnosis, the date of last follow-up are, of course, absolutely reliable, and this can be shared easily. The limitation I see with sharing is actually legal. In a sense, and that's one thing that we have been struggling with within Huracan and with Javier and all the teams, which is we ask patients their non-opposition to be put in the electronic database. They can say they can opt out, but we do not have them sign an approval on I can share your information with of course not the pharma, but even abroad, and that's where we should improve as well. I forgot to mention that.
I think if we add a new items, COVID vaccination, yes, no, I think we have some big problem.
Yeah, probably yes.
Javier?
Yeah, as I mentioned, in some programs, for instance, I remember the program for which we were checking the quality of several items, surgery, but also chemotherapy and other items. We had to make follow-up, obviously, in order to detect recurrences or even death. And in this sense, the longitudinal follow-up was necessary. But as my colleagues mentioned, the higher the number of items in the database, the lesser the compliance, and this should be found a balance. I remember the superficial or deep. This is is important even in the staging, but depends on the hospital. If a data entry was in charge to that, if this data entry was not trained, this was impossible because she or he was unable to decipher what exactly means superficial or deep tumor. So this is important as well to take into account. The number of items you are collecting is important, because if it's huge, then the compliance is for sure is lesser.
It is no sense to spend a lot of time to have the quality of the surgery, R0, R1, to spend a lot of time to have this information and not to have the date of the relapse. You cannot make any comparative study if you have no this information.
Yeah.
Very good point. I think if we summarize this discussion, then we, I think, all agree it's a very hard, tough challenge, unsurmountable challenge to have good quality, and basically there is just no good solution. On the other hand, what is the goal? What do we want with the data? Let's say, I think the ultimate goal needs to be outcome prediction modeling. But the question, well, first, do you agree with this? But second is, if so, how do we get there? What are your thoughts? I mean, I think that's the ultimate goal. We want to learn from the data as much as possible, but what do you think with this statement?
I don't know. Is French for sure? A French sarcoma group has the biggest data. I think they could design intelligence, artificial intelligence, to put in action in this database. But I think it's difficult to go further in prediction, for instance. Because yeah, ideally you have to melt data from molecular data and clinical data and radiological data, for instance, and this is several layers of information, and I think it's not easy to design this kind of analysis, but it's obviously currently it's possible to do that. But it's not easy, I guess, because
I think we all agree here too. I remember from in the June French Sarcoma meeting, there was at least a talk, or I think even a session about AI and outcome prediction. And I think that inspired me much. So I concluded at that time in my own head that the French Sarcoma group is going in that direction.
Yeah, we have several projects which are ongoing. One which is submitted. I can share the results with you. Two type of projects in this direction. The first one is, and all are image recognition based, which means you look at the slides and you make a diagnosis. And you merge that with clinical data for one of the projects. So the interesting information is that this electronic grading, if you can call it that, after the pathology grading, the molecular grading, the electronic or artificial intelligence grading. So the paper, which is submitted in a relatively small number of sample and centers, because this was very experimental, suggests that it may be superior to other grading. But I would call it preliminary, even though that's encouraging. The major input coming from the analysis of images. One thing which struck us was that it was superior to the French grading, to the molecular grading, and to the circulator as well. But that's a relatively narrow 2 centers, high burden of work for 2 years. You see this type of things. We need confirmation. Another one, which is more funny, maybe, but I share it with you, is to try to recognize molecular structures, molecular alteration, looking at the slides. Distinguishing lipoma from well-differentiated liposarcoma is a topic. And it's a bit early, so I can tell. But so that's the type of project that we are that are ongoing in the group, and I know that there are several other projects on image recognition, on CT scan as well, but I may not be aware of everything. Axel maybe knows better.
Sorry.
You have a project of image analysis, if I remember correctly, in Gustave Roussel, right?
Yeah. One on the other, it's a physical aspect. It's okay. We can have a prospective objective to have this database, but also we can the opposite. More we have data, and more we can make also retrospective analysis. So, yes, due to the evolution of our knowledge in the field of sarcoma, if you want to, now we have the NTRK fusion. We can back to the dossier the importance of the nature of the initial biopsy, MRI versus another CT scan. We can make a lot of retrospective study also to see the impact of one items, one histological subtypes, one pathway, one. So more we have data, more we build prospectively a large database, more the younger physician in the future will analyze. We can analyze all the. My message is to try to work together to collect prospectively all the cases with not a lot of items, and to leave this database, to come back to the database to increase the quality of the database for the future generation.
Awesome. I think my very last question refers again to MDT. Axel also pointed out how important it is that we should not only focus on discipline thinking, but on the entire, all disciplines together. And referencing Michael Porter, the father of the value-based healthcare, he says, the system creates what it's designed for. So my question is, what can we do in building up networks that we can strengthen the MDTs within such a network and also within the institution? What do you think are the ingredients to foster this?
I would really love to hear the answers of everyone around the video, but the first one, I think it's would be to consider it as a place where one can build a career in easily and friendly. That's a major thing which can guide success. It must not be, in particular for sarcoma, but we are speaking of sarcoma here. What people like is that actually it's a kind of friendly, open, everyone says yes place where people can build. And that's why people are coming, even though we have this shortage of doctors we all have.
We have changed our policy in our MTD every Monday. At that time, we see maybe only 20 files. Now we have 70, 80 files each week. So we spend less time, and we invite, it is a place for education. We invite all the resident or fellowship, foreigner to see how it is organized, and then how also with pathologists and radiologists, when we see a lump and we make the biopsy, it is a place where we increase our knowledge when we have the data on the biopsies, the radiology assessment, and then we elaborate a strategy. So for all the people in the room, they increase the knowledge of taking charge of the patient with a soft mask.
Javier, what are your thoughts on this?
Yeah, nothing new. Nothing else. I think is our group, for instance, has grown in a multidisciplinary base, and I think the involvement of each different disciplines, different specialists is important, and to have everyone is relevant in a local hospital and also in the network. So I think they have their own space, their own place to develop their knowledge and to share in a very good fashion. And I think to give responsibilities is very nice, very nice as well, because this has been our experience, and now there are a lot of people enjoying with their added value in the group or in the committee. So I think it's not easy, but the ingredients, as Jean-Yves say, is to be very kind and to give space and to give responsibilities, and everyone gives relevant knowledge, for sure.
To be honest, I'm very happy about this, let's say, final statements. because we were talking about data and AI and everything, but it boils down to the human factor. And in the end, we are physicians and we take care of the patients, and I think that's what counts most. I think we come to a conclusion. Any final words from your side? I think it's a highly interesting topic discussion. I think we learned a lot. I think it's a multi-step process of building a network. Just several challenges at several steps, and for sure it's ongoing. It never stops, and we continue to improve. We have to. But please share your final words to this webinar.
Maybe only one word. The key issue of each sarcoma group is a friendly group. It's very important. Name friendly.
Yeah, for sure. Thank you very much for the opportunity to share.
I'm very happy about this discussion. I think we learned a lot. It's a great addition to start the year with such a webinar. I'm really looking forward. Thanks for your sharing your knowledge and your experience. I think it's just inspiring for continuing our work. Thank you so much, and I hand over to Charlotte again.
Thank you.